patient was a man in his early 60s, a never smoker, had had tissue-based testing for EGFR mutation, which had shown an exon 19 mutation. He was treated with erlotinib. He had side effects of diarrhea and rash that were managed, and he was treated for about a year before a decision was made that subsequent line therapy was required. This patient actually had been observed for a few months of that year with asymptomatic progression, but then he started to develop a little more cough and a little bit more shortness of breath, and we were able to correlate it to a central lung lesion that we thought was the cause. And that was actually the lesion that was then biopsied for his T790M testing. Repeat molecular testing was prescribed. The method to acquire tissue for this was discussed at our multidisciplinary tumor board, where his old and new scans were put up on large screen for comparison, because we're looking for a spot that's actually growing. And a discussion ensued between myself, the interventional pulmonologist, the interventional radiologist, and the surgeon about the safest and most efficacious way to acquire tissue. And we made a decision to do so by bronchoscopy. That testing was successful and revealed the T790M mutation with no complications from the biopsy. We prescribed osimertinib. He did still have some diarrhea and rash, but less than he had had on his first line therapy, and he did have a partial response. It was tolerated very well. He actually had less rash and less diarrhea than he experienced on his first line therapy. And one character that toxicity tables and even maybe quality of life measures don't always get at is that global sense of well-being, that patients say, I feel well versus I feel sick. And this patient had a dramatic improvement in that global feeling of well-being that he thought that he really felt quite well on the therapy.